Hi, my name is Alex Vu. I'm from NYU Langone, Brooklyn. I want to thank SAGES for giving me the opportunity to speak about some of this interesting data that we've been collecting here at NYU. I also want to give a shout out to Dr. Cho Huang, Dr. Derek Lim, Dr. Yunzi Qian, Dr. Chokwani, Dr. Tursunova, and especially Dr. Fursley for all the mentorship and collaboration on this project. I have no conflicts of interest or financial ties to disclose. Insurance companies mandate medically supervised weight loss programs and evaluation prior to bariatric surgery. But the question is, are they effective in decreasing preoperative BMI for those with very high BMIs? Just to give you a short timeline, somewhere in the mid-2000s, late 2000s, there was a lot of accumulating evidence for both sleeve gastrectomy and gastric bypass for being effective ways of addressing morbid obesity. And alongside that, in tandem, were these insurance mandates. Now, a lot of data had been collected about these mandates, and in 2011, the ASMBS released a statement against these mandates, saying that insurance-mandated preoperative weight loss is not supported by medical evidence and has not been shown to be effective for preoperative weight loss before bariatric surgery or to provide any benefit for bariatric outcomes. And again, all this evidence from 2011, 2016 started to accumulate, and again they released another statement saying that the requirement for documentation of prolonged preoperative diet efforts before health insurance carrier approval of bariatric surgery services is inappropriate, capricious, and counterproductive given the complete absence of a reasonable level of medical evidence to support this practice. And yet, 2021 and beyond, this still persists. So the question is, why are insurance companies mandating this sort of delayed preoperative weight loss program evaluation? Now, at best, they're doing this because there's a lot of evidence for preoperative weight loss that benefits the patient. All from data from 2007 till now shows that you can decrease operative time, you can decrease length of stay, you can make faster post-operative weight loss. And even a study in 2016 from Scandinavian registry data had suggested that you could even, in extreme weight loss preoperatively, can decrease postoperative complications. So if preoperative weight loss works, then why aren't insurance-mandated delays effective? And the simple answer is that insurance mandates don't necessarily mean weight loss. If you look at all the major plans in New York City, they require you to see a surgeon or a provider for 6 consecutive months, but they don't usually require any type of weight criteria. You have to get weighed every single month, but you don't have to lose any particular weight. Some insurance companies will advocate for and mandate a small percent of 5% weight loss, but that's far beyond the minority of insurance companies. We know the data on insurance-mandated delays are ineffective. The data shows no difference in postoperative complications, no difference in postoperative weight loss, no difference in readmission or reoperation, and even some patients gain weight. And it may be even harmful, showing that some data shows increased morbidity and mortality, increased dropout rates, and from a systems perspective is not very cost-effective. And yet, the insurance mandate still persists. And we worry how this affects the most vulnerable obese patients, especially those with BMI greater than or equal to 50, because we know those patients suffer more perioperative complications than the ones who are less than 50. So to our knowledge, there's no existing study on this super morbid obese population and the effect of this 6-month delay. At NYU, we collected data from 3 campuses. We looked for 6 years, 2015 and 2021, for anyone who had a BMI greater than or equal to 50, they had to undergo an insurance-mandated 6-month visit, and they had to not have any prior bariatric surgeries. And our outcome that we were interested in was BMI difference and percent weight change. We also had secondary outcomes, mortality, morbidity, and intraoperative complications that we also studied. We validated this data through direct chart review. We performed paired t-tests on the BMI and percent weight loss. We used chi-squared for categorical variables. And this is a table of all the baseline data. Just to summarize, on the right side is we had an N total of 130. All of them underwent Roux-en-Y gastric bypass. They had an average delay of 8.4 months, average BMI 57. They were predominantly female, and they were quite sick, ASA score of 3. If you look and compare the BMI at the initial visit, and then 6 months later, right before surgery, they did actually incur a statistically significant weight loss, 1.51 points in BMI and 4.8% total body weight. But the main message right here is that the BMI change is significantly different, but it's clinically insignificant. Here's why. Our study showed, again, a 4.8% total body weight loss. But if you look at some of the other studies, particularly the one that advocates for decreased postoperative complications, that Scandinavian registry study, they compared the 75th percentile and the 25th percentile, and that equates to about 10% total body weight loss and 5% total body weight loss. And if you are in that 75th percentile category, you will see a 13% decrease in complications. This is based off 2016 data in Scandinavia. So we have the argument that maybe this makes no significant difference. But what if we looked at the people who were able to lose a lot of weight, more than 5% weight loss total, compare them to the less than 5%. Do they differ in comorbidities? Do they differ in intraoperative complications? Do they differ in mortality? And the answer is no. Even if you were successfully losing this weight, you do not have any change postoperatively. And of course, we have some limitations to this study. It's a small sample size. It's retrospective in nature. But I think this is some decent evidence that suggests that this insurance-mandated delay does not clinically impact pre-op weight loss. Even if you have significant weight loss, it doesn't make a difference in your intraoperative complications or mortality. And we really look forward to studying this in a prospective manner at our institution. Again, I want to thank SAGES and the moderators here for giving me the opportunity to speak on this data. And I hope to connect with you all and to see if we can make a difference for these very super morbidly obese patients. Thank you.